Question is, if the cancer is confined to the organ, can you die from it? No. It's got to get out either from local extension, where it grows right through the prostate capsule into the soft tissues around it, or it's got to spread to your bones or your lymph nodes. You know, rarely it'll go to your liver or your brain. So it has to spread outside of the prostate gland. So one of our criteria for doing the focal therapy is that obviously the cancer needs to be confined to the prostate gland. Question is there a way to prevent prostate cancer? The answer is no. Not that we know of yet. There's all kinds of stuff that you see out there, pomegranates, tomatoes, all kinds of, diets. Some of these diets will result in a reduction of your PSA, but that's just because it's removing some of the ingredients that allows your body to make the PSA. The cancer's still there. And then there are other therapies that can actually bring out prostate cancer. Turns out prostate cancer is very hormonally active, and in an era that embraces this biocompatible or bioequivalent hormone replacement where guys get testosterone therapy. While there's some medical reasons why that may be a good thing to do, if I'm getting any testosterone therapy, I'm going to get my MRI for sure, because that testosterone therapy can take a little prostate cancer that was kind of quiet and cause it to grow and enlarge and get more aggressive because they're hormonally active. So probably once a month we actually see a patient who's on testosterone therapy that's referred to us by primary care docs that take care of this hormone replacement stuff, and the PSA suddenly makes a little jump. And they're worried that the testosterone may have caused a small prostate cancer to wake up. This is a good way to look for that. If this is negative, then they can continue with their testosterone therapy without, worrying too much. The question is, how do you know that they've got a multiparametric MRI program that's going on? You need to ask some really specific questions. One is, do they have a computer that does all that post-processing? So the CAD, the computer-aided detection, hardware and software that does it. Do they have that? The second is, are they giving contrast and doing the diffusion-weighted imaging? If they're not, it's the old type of MRI. Okay? The third is, are they doing MRI-guided biopsies? Okay, the last thing you want to do is go to some facility and they do an MRI of your prostate gland and they say, oh, you know what, you've got a tumor suspicious region. There's a 50% chance you have a prostate cancer, but we don't have the expertise of doing an MRI-guided biopsy. We don't have the hardware or software. You're on your own. Also ask them, if they see a tumor suspicious region with their multiparametric MRI, do they have the hardware and software to do an MRI-guided biopsy? And then the fourth question is, how many have you done, kind of a thing? Because it's early on with this technology, you want to hear that they've done 50, 100. We've seen 700 patients now. 480 of the multiparametric MRIs, 220 of the MR-guided biopsies. You want to hear that they have a substantial experience interpreting these as well.
I've heard a lot about the ultrasound color Doppler, which for the diagnostic phase. How is that different from MRI?
So ultrasound uses sound waves, and color Doppler uses the ability to measure the change in frequency of sound waves. The way to think of that is a train. When you're standing at a train station, when the train's coming at you, it's like, right? So when it's coming at you, the frequency of the sound waves is actually increased because it's the frequency of sound plus the velocity of the train. When it's going away from you, the frequency goes down because now the train's moving away from you, so the velocity of the train is subtracted from the speed of the sound waves. Well, that frequency shift is called Doppler, and it's used for Doppler radar at airports, right? You see, weather, right? Looking for tornadoes and hurricanes. Well, we use that with color to look for some of this increased vascularity associated with prostate cancers. And in some hands, there's one guy here in Southern California that's really good at it. And a small number of people have some really good results with it. But it's very, very user dependent. Clearly, in most cases, you're still stuck with the situation where you see the gland well, but you can't really see the cancer within the gland separate from the rest of the gland. at least not nearly as well as we do with MRI. Question is, why do the truss at all? We're actually having more and more patients that are coming directly to us as referred by primary care docs that do not have the truss. So we're seeing that kind of grow with time. So the question is, if you had a truss, can you switch over and have an MR-guided biopsy? The answer is yes, at any point in time, before or after. We like you to wait 6 weeks after the truss biopsy to have the MRI-guided biopsy, because you get some bleeding and some changes in the gland related to the biopsy that we like to resolve a little bit before we do the MRI, so it doesn't get confused. So the question is there any other place in the desert doing the laser ablation? The answer is no.